There we go.
Okay, thank you so much for having me. Can you just let me know that you can see my screen?
We can.
Okay, perfect. So I'm going to keep this very brief. And the thinking really was just to introduce Next Biosciences to the community. I think many of you are familiar with the company and the work that we do. So we are a biotechnology company that works across different services, so stem cell banking, biologics, but then also within genetics. And in the genetics area, we focus mainly on reproductive genetics, so pre-implantation genetic testing, products of conception testing, non-invasive testing. So these are some of the tests that you will be familiar with, that you may have interacted with our team with about. And what I also wanted to do was highlight some of the research that we do in these different areas. Some of it is, how can I say, more sort of stats-based. So every year, our lab and clinical team put together stats documents for our various services that we then distribute to fertility clinics, gynaes, so healthcare professionals that request the tests that we offer. And the thinking really here is to make sure that the results that we are producing and that we are seeing for these different tests, that they are in keeping with what we would expect based on international standards, what we see in literature, and also a way for example, fertility clinics to make sure that they are maintaining their results in keeping with international trends and clinics as well. So as well as these documents that our lab team and clinical team work very hard on every year to put together, they are quite comprehensive, and you can see some of the things that we cover in these documents. We also do other research. So our lab teams have presented at various gynae conferences with abstracts that have been presented and posters that have been presented. More recently, Clodie and I have been, and Clodie, some of you will know, Clodie Achenbach, who is based at UCT for a few years. We were involved in a joint publication with international laboratories looking at NIPT for rare autosomal aneuploidies, and that was recently published in Frontiers in Genetics. So we were quite proud of that article that was published. And then I've got some snapshots of some of the other local publications that we've contributed to, and then also some posters. And then mainly the forums where we would present our research would be at the gynae conferences that I mentioned, the fertility conferences. So these would be both clinician and patient focused. We have submitted, our team have submitted a number of abstracts for the genetics conference next year. And really what we also wanted to highlight this afternoon is that our team is very open to collaboration with the genetics community. And this was just to give you a snapshot of some of the work that we do, and that we are always open to try and collaborate where possible. And you're very welcome to reach out to us at any point if there's anything that you feel we may be able to work together on. So I'm very much looking forward to all the talks from this afternoon, and good luck to everybody that's presenting.
Thanks, Kelly. Kelly, is there any particular avenues that people can contact you on? Do you want them to contact you directly, or how else?
Yes, so I probably should have included that, but you're welcome to contact me so we can circulate that afterwards. You're welcome to contact me directly if there's anything. So you have an idea now sort of where we placed within genetics, so mainly reproductive genetics. So if there's anything that's of particular interest to anybody that's looking for some, I know we're always looking for projects for lots of different reasons, for students, that kind of thing, but you're welcome to contact me directly. We can chat about anything and then see how we are able to collaborate on whatever ideas you have.
Perfect. Thank you so much.
No problem.
Okay, so next up we have our first presenter, Willem Pretorius, who is going to present on medical practitioners' use of genetic counselling services in Cape Town. So Willem, when you're ready, can you please start to share your slides?
Hi, everybody. Just confirm, Monica, can you hear and see me?
I can. Yes to both.
Yeah. And presentation slides?
Yep.
Stunning. Okay. So hi, everybody. My name is Willem. I'm one of the genetic counseling interns at UCT. And today I'm going to present to you a snippet of my research project. And to start things off, I can only assume that most of you have had that interesting conversation with either a friend, a family member, or just a colleague on, so what do you do for a living? And then you got very interesting responses. And then sometimes you get nice responses like this individual, which compares or talks about genetic counselors being like a preparer, a bearer of bad news, but also someone with information and a plan, and also a handshake or a hug, you know? It's a consoler and also a counselor, almost a consoling counselor. And I thought that that was a nice way to introduce what we're going to be talking about for the next few seconds or minutes rather. And that is that there are still so many people that don't know what a genetic counselor is, what they provide, how people can actually refer to them. And if we think about genetics in society, there are so many people that are requesting genetic testing, especially in first world countries. Direct-to-consumer testing platforms are booming. And then we have so few people who can actually interpret these genetic results. And then if we think about the medical profession, there's also so many people that are currently in the medical workforce who completed their training before the completion of the Human Genome Project in 2003, which means that their genetics training is definitely a lot different from what people can have today. And if we just consider in the last decade the amount of research that has been done, the type of genetic testing that is available, it's such a massive endeavor to actually incorporate this into current practices. And who would be the people to actually do that? It's in a short answer, it's quite a difficult job to do. But these were all the things that I've been thinking about when I try to create my research project, because I have read that there are perspectives that have been done about genetic counseling from the viewpoints of patients, from the viewpoints of general practitioners, and then also from genetic specialists. But I couldn't find research that has been done looking at medical practitioners who actively use the service and ask them what do they perceive from genetic counseling in their practice. So essentially the aim of my project was to evaluate the service in Cape Town, or more specifically in South Africa as well. And I thought about doing that by breaking my research question down into 4 main objectives. The first being to identify when did medical practitioners actually start utilizing genetic counseling services? How do they explain genetic concepts to their patients and the genetic service as well? Are there any advantages or disadvantages to referring their patients? And lastly, are there any other ways to promote the use of this service with medical practitioners who are not currently making use of it? And I thought the best way to also reach these objectives to answer my research question was to do interviews. Thanks to COVID, I had to do this face-to-face in an online format, but it was still retained. And I added the bonus of doing the interviews in both Afrikaans and English, because I thought that would give it an interesting depth, because there's still some doctors here who consult their patients in Afrikaans. In terms of the participants, I thought the ideal people to recruit would be medical practitioners who function in a private practice capacity, because they refer patients directly to a genetic counselor with a specific purpose. And that's what I wanted to know. I did not consider state-based medical practitioners, because they usually would refer patients based on a protocol. And if there are some doctors or medical practitioners who work in a dual capacity, so in a state and private capacity, I would also consider them as ideal candidates as well. How I went to actually get these individuals, I approached genetic counselors in Cape Town, provided them with an invitation letter and the approval from the ethics committee, and they can just send that to the medical practitioners they have received referrals from, and there they can contact me directly, or the research team, or they can say to the genetic counselor, I am willing to do an interview, and we can just exchange contact information from there to make the interview. So this is just a slide to show you how I went about doing the interviews. And then I did some transcription and incorporate some interesting aspects into the subsequent interviews, complete the coding, and after having all these different codes, I condensed them into categories and eventual themes, which we will be talking about in the next few slides. In terms of what I found, so I reached out to 8 genetic counselors, 5 of which were happy to help out, and they sent this invitation letter to about 41 medical practitioners. Just note that there might have been more than one genetic counselor reaching to a single medical practitioner, so it might be a little less than 41. And the amount of MPs or medical practitioners that reached out to me saying that they were interested was 16, 12 consented to actually do the interview. And it was almost a 50-50 of having Afrikaans and English interviews, but I had one more Afrikaans one at the end. And the average length of the interview was approximately 36 minutes long. Also interesting, the majority of the participants were surgeons, so 6 out of the 12 or 50% of the cohort. And if I look at this entire cohort and ask them how many people they refer on a monthly basis, they would say about 52 to 81 patients per month for a genetic counselor. With regards to the discussions I had with these participants, I thought that the interviews boiled down to 2 broad themes. The first one being barriers to integrating genetic services in South Africa, and the second theme being the appreciable impacts of genetic counseling. And sadly, due to a restricted amount of time, I will only touch on some of these components and share them with you. So with the first theme of barriers, I broke it down even further into 2 sub-themes. The first sub-theme is with regards to the identity of genetics and genetic counseling services. Most of the MPs from this cohort felt that they were exposed so late, only in their specialist training, to what a genetic counselor is and what they provide for their services. And they thought it would have been a great idea to have more exposure to them in their undergraduate training. There was also interesting discussions about the professional title of genetic counselor, where some people thought that counselor itself has this negative association or is not comprehensive enough to explain what a genetic counselor actually provides a patient and the referring doctor. Even the Afrikaans term genetische raadgewer felt to some MPs that it's not comprehensive enough to capture what this individual actually provides them. And then the final point from this sub-theme, the genetic healthcare management proficiency. There are so many of people in this cohort who still feels more than comfortable to refer their patients for genetic testing with a genetic counselor. They would not do it themselves. They described it like, let the cobbler stick to his last. So let the experts do what the experts do, and they can do what they do. And the next sub-theme, maybe unsurprisingly, barriers in terms of restricted available resources in South Africa. The first being monetary constraints. And we should know and acknowledge that patients are struggling financially, and genetic testing is not cheap. And in terms of human resources, there are not a lot of genetic counselors in South Africa, and some of the MPs felt that if they even refer patients, they would be so afraid that they get lost in the system because there are so many patients and people are not accurately being followed up. And in terms of time, I think this quote in the top right corner captures it quite nicely. Doctors don't have the time to consult all the patients and discuss the intricacies of their genetic diagnosis. Also, in that moment in time, they cannot discuss all those things. The patients are overwhelmed, and they feel also very bad to not spend this length of time with them, even if they can provide genetic counseling service, but it is a barrier for them. And the final point here is guidelines, where majority of the MPs used first world country guidelines, and they constantly need to deviate from those guidelines for their patient care management because we don't have the resources here. And they propose that one should actually create new set of guidelines for third world countries or middle income countries to help with the resources that are actually available. Looking at the second theme, the appreciable impact of genetic counseling, I thought this quote on the left-hand side takes it very nice together, the first point of the perceived skill set of a genetic counselor. This individual says that a genetic counselor is a source of information. He's a source of sifting. They are part of the multidisciplinary team, and they're also important for coordination, almost like this glue or connective tissue, if you will, to keep everyone together and going forward with their management. They also see genetic counselors as trustworthy, being able to hand over their patients and knowing that they will be okay. And having these individuals to actually bounce ideas and discuss very difficult emotional cases with, that really provides them with a support structure that they don't have, especially in a private capacity. And then they can also contact the genetic counselor as being a knowledgeable resource of information, because they are the experts in the genetics field in their own way, and they can provide the medical doctors who don't have that knowledge with just a little bit more, even to help provide some other options to help focus care management for a patient. So in terms of the impact of genetic counseling, none of these individuals could see a future without having a genetic counselor in their team or just part of their medical management. And yes, there are still so many barriers to incorporate genetics in South Africa, be it in the form of resources or genetic knowledge, or even the personality of the doctor who says, I can do it myself. But the fact of the matter is, one needs to think about these barriers as stepping stones, how to get past them, because we adapt, and that's what we're good at. And then with regards to advancements in genetic technologies, maybe it would be a good idea to have more of these experts in their field to help discuss these things in terms of what could be appropriate to use in their practices going forward. Sure, there are some limitations in this research project. Most of the people I have recruited were surgeons, so it could be a bias of information, right? And it's limited to Cape Town. It would be so impressive to see what other people in South Africa actually think and perceive from genetic counseling services. And with the option of having more languages, yes? Okay. Sorry. And the idea of having more languages available.
You what? You what?
Okay. I can hear someone else in the microphone, but anyway, there are so many prospects for future research. So in conclusion, I think it is time for us to address the elephant in the room in South Africa and engage the medical community and the population into the genomics era with the assistance of genetic experts, which includes genetic counselors. And I leave you with this quote, which essentially points out something very important, I think, that is genetic counseling is still underutilized. Thanks.
Thank you so much, Willem. I apologize for the noise interruption. I'm trying to mute people on entry. Does anybody have any questions for Willem? That was an excellent talk. Katrine and Nikita both have questions. Katrine, you can go.
Thank you. Thanks, Willem. That was really very nice. And I particularly liked your last slide, which is where my question comes in, where you say address the elephant in the room. And I agree with you. And I like that way of putting it. How would you do that? So practically, if you had, you know, the perfect world and you could just go, what would your one recommendation be that we do to address this issue?
So I think one of my participants took it very nice together, and that is to be even more involved. They want physical presence, be it in a meeting, being anywhere, just to at least have that presence, because most of the doctors explain that they learn best from lived experiences. So if you are there, they would remember you. And one of the quotes that I really like as well was, sometimes you just need to show the obvious things and then they would understand to use it more. So it's just making the obvious obvious. And I think that would also encourage more people to see what genetic counseling can provide, because for many people it's still abstract, but if you see it, that would make a longer
see a person every day in the hallways. Okay, thank you.
Nikita?
My question is actually along the same lines, Willem. I think one of your fourth objective was to ask how, you know, what the recommendations were on how we target other doctors who don't utilize our services. Were there any other recommendations of how we can do that?
Yes, so some of the participants actually said that they first were introduced to genetic counseling through lab flyers. So some people suggest that if a genetic test is requested, one should have a list of genetic counselors that one can approach to help interpret these results, which I think is a good proposition. And also have more people involved in multidisciplinary teams in whatever private capacity or be it in a state capacity. One just needs to be more involved. I think that was the major take-home message from this group, is be there, because that's how they will talk and engage and ask questions. One of the doctors actually said that don't hide away in your office, because that's not going to work.
Thanks, Willem.
Yeah, I guess it's interesting because here we're sort of talking to the privileged few who do have access to genetics, whereas it would be interesting to see what the response is like in provinces where people have had no other option but to adapt because they haven't had the access. So yeah, lovely presentation, Willem, and good research. Well done. Okay, so next up we have Barry Shingwanyana, who is presenting on assessing patient recall, understanding vocabulary of genetic concepts in a South African setting.
Okay, Monica, I just want to confirm if you can see my slides.
I can.
Okay. Okay. I'll start now. So good afternoon, everyone. For those who don't know me, my name is Barry Shingwanyana. I'm a genetic counselor with Vet. And then I think just for the sake, to be on the safe side, I'll switch off the camera now and then I'll start. Okay, so as Monica mentioned, I'll be presenting some of the findings from the research that I did as part of my master's. So the title of the talk is Assessing Patient Recall, Understanding and Vocabulary of Genetic Concepts in a South African Setting. So for an effective communication to occur, you need the healthcare. Sorry, Monica? Can you still hear me?
I can.
Okay, I'm sorry about that. Okay, there was a. Okay, so you need an effective communication between a healthcare provider and a patient to facilitate a successful outcome. So what I mean by a successful outcome is that we will allow the patient to comprehend the medical information that we're discussing with them, and also allow them to make informed decisions. So we know that in the healthcare setting, English is the preferred language, with over 80% of the communication occurring across language and cultural barriers. So for a country like South Africa, which is multilingual, we know that miscommunication is most likely to occur, especially if the healthcare provider and the patient are from two language backgrounds. So we have got this concept of which can be described as having the motivation to gain access to and use medical information for good health. So we know that for most of our patients, especially in the state sector, they've got low literacy skills, as reported in the study that was done in 2010, targeting primary healthcare patients in Gauteng. So linked to the health literacy concept, we've got the concept of genetic literacy, which can be described as having adequate information and knowledge, and as well as understanding of genetic principles in order to make informed decisions. So internationally, studies have been done and to assess how the lay public really understand their understanding of genetic concepts, and they have reported on that there's misconception and confusion when it comes to genetics, regardless of the conversational familiarity of these terms. So we've got this study that looked at a population of women and men in the US. It reported that there was a misunderstanding of basic genetic terms in about 75% of those cases. So no such study has been done in a South African setting. So given now this general misunderstanding of genetic concepts, we need healthcare providers such as genetic counselors who are trained in genetics to be able to educate, communicate, as well as explain complex genetic concepts and information pertaining to disease to patients in order to promote genetic literacy as well as offer the emotional and the psychological support. So currently, we know that there are no words that exist, African words that exist to describe genetic terminologies, and this can be a challenge for South African genetic counselors, especially when they have a patient in front of them who has got limited English proficiency. So in our study, what we aimed to do was to assess counselees' recall and understanding of genetic concepts following a genetic counseling session, and hopefully develop a South African specific vernacular genetic vocabulary. This was done through assessing patient or counselees' recall and understanding of genetic language and symbols that was used with them during their genetic counseling sessions, and also to determine what words would the counselees would use in their own home languages to describe the genetic concepts that were discussed with them in the session. So we targeted caregivers of children with Down syndrome that were attending their routine genetic counseling session. Down syndrome was chosen because it's one of the common genetic conditions that we see in our clinic. At the time that I did the study, on average at our unit, we would see about 9 new cases per month. So ethical clearance was also obtained from the Human Research Ethics Committee at VETS. So prior commencement of the study, I sat down with the 8 genetic counselors here at the division to brief them on how to standardize their consultations in terms of the diagrams that they're going to use to help explain concepts to patients, and also the information that they would discuss with the patients. Anonymity and confidentiality were ensured. We didn't gather or obtain any identifying information from the participants, and all the information that we gathered was also stored in the database. So we included Black South African individuals whose first language is not English, that were over the age of 18 years, and they had to be receiving genetic counseling for a diagnosis of Down syndrome for the first time, and the session had to be conducted in English. And we excluded those individuals who were counseled in languages other than English, or those who received basic genetic counseling sessions due to limited English proficiency. And for language reasons, non-South African individuals were excluded. So this is just an overview of what we went through. So the recruitment took place at our state genetic clinics here in Johannesburg. And in total, we got 14 caregivers of children with Down syndrome. So this was a quantitative and cross-sectional study. So after their routine sessions, I would approach them and then tell them about my research. And then if they showed interest into the study, then I would administer a questionnaire after their sessions. So the data that was collected was analyzed descriptively. So we sort of like had to come up and design our own questionnaire because such study has not been done before. So we had a 3-part questionnaire which focused on demographics, recall and understanding, and genetic vocabulary. So on the section of recall and understanding, it was based on 5 questions out of 29 points. So just some of the pictures here that I've included here on the left, you see you've got a picture that shows abnormal fertilization where there's an extra chromosome in the egg, and then also just the karyotype that indicating Down syndrome. So our questions were based around these pictures. So this is just an example of how we phrased our questions. So the first question for all was just asking them if they recall seeing the picture in the session, and then they would say yes or no. If they said yes, then we would continue into the second part of the question that says, okay, fine. Now that you've seen the picture in the questionnaire in the session, what do you understand about the picture? And then here we had a list of possible answers that we expected the participants to sort of like give to us. And for each answer that they would get right, we would award like a point for that. So this is based on this picture of the abnormal fertilization in this slide. So if they said, okay, we see an egg, we see a sperm, we see 23 chromosomes from the father, 24 chromosomes from the mother, we just award them points. And the section on genetic vocabulary was open-ended section. So the participants would volunteer words, terms, explanations, or analogies to describe the selected genetic terms in the box. And finally, they provided us with existing names in the community for children that are living with Down syndrome. So you can see here that most of our participants had studied biology or life sciences, and then 2 fathers had attended the genetic counseling sessions, and then also took part. Then they agreed to be part of my study, and then about 35% of our participants had a tertiary training, and most of our participants they identified as isiZulu speakers. And then when we look at the age of the child at the time when we recruited them in months, it was like a median of 9 months. And then in terms of the questionnaire score, in total, we had about the mean score of 22, which then in terms of the responsive rate, the correct responsive rate was about 75.9%. So coming to the terminologies now, when we look at, just to say that we had about six ethno-linguistic groups that were included in the study. So when we look at Setswana compared to isiZulu, in Setswana, we only had one recommended terminology for the word egg, which is leye in Setswana. And then when we look at Zulu, for all the words that we had, there was an explanation, or there was a recommended terminology. So if we look at 18 participants said in Zulu, they said they would describe a gene as being Izakamzimba or Insosha, or they would define, or they would refer to a cell as Isikubu. And then for this one, we saw something that was also very interesting to us, where we have this concept of word borrowing, where we've got less developed languages borrowing words from developed languages like English. So when we look at isiZulu, the participants said that they would refer to genetics as ama-genetics. And when we look at Xitsonga, for the word chromosome, they said they would use something like the chromosome or ama-chromosome in Zulu. And in Xhosa, they would refer to a cell as Z-cells. And I'm just going to discuss the analogies that I got from the isiZulu participants. So for genetics, they said that how they would explain this, they would say, indlela umzimba osebenza ngawo, which in English translates to the way in which the body functions. And then for inheritance, they say they would say something like ufuzo aluthole umzali wakhe, which means inheritance from their parents. So for the names that exist in the communities for children with Down syndrome, we'll look at the first three. So in Tsonga, we have got Idomu or Shapenga, which both those names, they refer to a stupid child or a crazy child. And in Northern Sotho, they said the name that exists is Waraha, which also translates to a crazy child. So you can see that there are negative associations to this. So in discussion, we know that, so we saw that less fathers were in attendance of the genetic counseling sessions. It's not surprising, because we know that South Africa has a higher rate of absent fathers, and also it might be the fact that the mothers usually take on the primary caregiving role. And this was an educated group of counselors that we recruited, majority identified as isiZulu speaking, which is in line with the demographics of Gauteng. And we can see that genetic counseling was sought in the early infancy period, and this has its own benefits. And about 75.6 correct response rate on recall and understanding, which indicated that genetic counseling was, the patients really understood what was discussed with them in the sessions. And we had more descriptive words and analogies for genetic types were volunteered from the isiZulu. And names that exist for children with Down syndrome were not appropriate. So in conclusion, there was a good recall and understanding of genetic concepts. Genetic counseling was proven to be effective. The use of illustrations to explain genetic concepts was beneficial to the patients, and the negative connotations for Down syndrome that exist in these communities, they talk about we need to raise awareness around genetic conditions, not only Down syndrome, and also educate the public. So we as genetic counselors, we need to be working together with African communities to do this. And the study may have initiated a new South African specific genetic vocabulary. So there were limitations to this study. As you've seen, our sample size was small. We would have loved to have more, but because of time, we couldn't continue with the study. And this is also not representable of all the South African native languages. The study may have been subjected to recall bias, as I said, that I interviewed this group of caregivers immediately post-genetic counseling session. So future studies could look at recall and understanding after a longer period of time, post-genetic counseling, and also include other more diverse language. I just want to say thank you to my supervisors and everyone who made sure that I get. Thank you.
Good job, Barry. Thank you. Does anybody have any questions for Barry? So Fiona's asking, Barry, Fiona would like to know whether you or other colleagues have made use of the words proposed by the counsellors in your counselling sessions following your project.
My Fiona, thank you for the question. I have personally used some of these, some of the analogies or the terminologies, but I think maybe I haven't really distributed the findings from the research to the wider community. So I don't think everyone has used it.
Sounds like a nice GCSA project. You can start a dictionary.
Thank you, Monica.
Nikita?
Thanks for that, Barry. So interesting and so needed in our country. You know, I'm hopeful that this is the start of lots of things to come. And actually, I was hoping that Andrew would make a comment here, as he's also looking into some local vernacular with some medical students. So I think I just wanted to congratulate you mostly on that. And then I think my question was, where's the publication? How can we do this? Because I think we all need to know about these words. You know, we don't have that many isiZulu speakers in Cape Town, but we certainly do see some, and I'd love to know about the terms. Thank you.
Thank you. Yeah, I think we had planned to publish, but I think my sample size is small. And then I think after completing, I had hoped that I would continue collecting data, but I think there isn't really time, but hopefully soon I'll find time to go back and get more data. Thank you.
Yeah, it might be a nice resource just to share with the community sort of in the meantime, what you've come up with so far.
Okay, Monica.
Kutala?
Thank you, Barry, for the great presentation. I just want to ask you, when I was doing hearing loss recruitment with my previous colleagues, I experienced that Xhosa people from Eastern Cape and Xhosa people from Johannesburg, they use terms differently. Did you have anyone from Eastern Cape and anyone original from Johannesburg to see if there's any differences?
I think I know what you're talking about, but to be fair, I didn't look into that. I think we just recruited from our Joburg clinics. So I'm not sure whether if their hometown is in Eastern Cape or they're actually full-time based here in Joburg. But that would be interesting to actually see.
All right, thank you.
Tina?
Hi, Monica. Thank you
Hello.
so much, Barry. Like Nikita was saying, Andrew is also looking at this, and the point that you were making, Kutala, can you hear me? Sorry, can you hear me? The point that you were making, Kutala, is that it's exactly what Andrew found, because he looked at Sotho languages. So there's Northern Sotho, Pedi, and Tswana, and that the dialects differ. So I think there's always a PhD, Barry. And I think what would make it a really powerful project is if the students across the country actually work together, because in Cape Town, of course, isiXhosa is the most spoken language, and then up in Gauteng it's Zulu, and then up in Limpopo it's more the Sotho languages. So I think we could have this huge big project actually. And I don't know if you know that the Indigene project was initiated. When Andrew looked into that, there wasn't really much happening. So I think coming from the south all the way up to the rest of Africa, I think it would be really powerful. So yeah, I don't know if yeah, there's nobody else who wants to comment. That's fine. I'm just saying PhD is not out of the question.
Yes, if I get the funding, I'm happy to do it.
Exactly.
I just want to say I second that, Tina, because these different dialects, you get different information when you ask questions from patients, and it will be nice to have these different dialects and knowing the patient, where's the patient coming from, and then you'll be able to use specific dialects to that specific patient.
Exactly. Exactly.
And then I guess the goal is to make genetic counselors that already in practice more proficient in this terminology. Okay, we've gone a little bit over, so I'm going to stop the questions there. Thank you so much, Barry. Next up, we have Sinead Cameron McIntosh, who's presenting on prenatal perceptions of the educational needs of children with genetic conditions that lead to intellectual disability.
Great, thanks, Monica. Can you see my slides?
I can.
Great, thanks everyone. So yeah, Monica's already giving you the title and everything. So my primary supervisor was Professor Tina Marie Vessels and co-supervisor Kalinka Papal. And just some background. So as we know, South Africa has a unique and challenging setting for special needs education. Historically, children with disabilities were separated and marginalized from their neurotypical peers, especially those from African and rural communities. So since 1994 and throughout the formation of the new government, several documents and laws have been put in place to try to rectify the previous injustices and discriminations. And the slide just briefly shows you a timeline from 1994 to 2015 of all the papers, goals, and acts that have been declared. So from the 2011 census, which is the last published one that we have, South Africa has over 200,000 students with one or more disabilities, and roughly only 513 government schools which are equipped to support them. And these include mainstream and special needs schools. So there are limited schooling choices, both government and private, and homeschooling choices for parents and caregivers with children with disabilities. So little is known about the difficulties that parents and their children face with genetic conditions that lead to intellectual disabilities. These children often have multiple challenges that result in their varying special schooling needs. So my methodology, so as we all know, research is a process. So there's a lot of feedback, a lot of back and forth, a lot of reanalyzing. So this basically just shows you how I went from questions to pilot interviews to interviews, revise more interviews until I got to my final themes and sub-themes. So I identified 48 candidates from the database. They were then contacted by staff and students to see if they wanted to participate. If they agreed, then I made contact with them and scheduled interviews. Some candidates did not answer, some of them did not attend the interviews. So from the 48, it filtered down to 9 participants that I interviewed. So I asked some demographic questions, which gave me the genetic diagnosis, the age, the sex of the child, their current challenges, and their family structure. So this table just summarizes the 9 and just shows you the different genetic conditions that were included. Okay. So the results, interestingly, most of the children were male. Most of the children had a sibling or another child that was living at home with them. And the relationships of the participants, most were married. So I used qualitative research with thematic analysis, and I came up with 3 main themes, which were divided into 2 sub-themes each, which I'll discuss further now. So the first sub-theme is family life. So participants spoke about life becoming a juggling act between work, a social life, and raising a child with special educational needs. And in most cases, life plans had to change. So moving house, adapting the house to suit the child, maybe only having one child, things like that. Advocating for the child to the family who did not always understand the genetic condition. So there was some stigma, some judgment from family members, which could then lead to a decrease in the support base, and participants who felt isolated and alone without their family support. It also affected the parents' relationships, with some of them separating and even marriage counselling, which in part they put down to the additional stress of having a child with special education needs. Those that did have siblings, the siblings were generally quite protective and involved with the child's development, especially if they were older. They would help the child develop some skills and look after them after school. And then because the study was done during COVID, I asked about how COVID affected them. And in most cases, it was negative in terms of losing jobs, being separated from extended family, and being stuck at home with schooling either completely stopping or moving online for those that had the resources. Second sub-theme is the child as an individual. So as we all know, children in general have different strengths and challenges. And in this case, some of the children had different medical, mental, and developmental challenges that relate to the genetic condition. So they needed different support therapies, like not everyone needed physio and OT, speech therapy, etc. Participants preferred to focus on their child's strengths more than the weaknesses, And they spoke about the children's determination, kindness, and resilience. And most of the children from the study made school friends at special needs school, but those that did attend mainstream school beforehand were sometimes bullied, which stressed the parents out quite a bit. Some participants felt that the teachers did not understand the child's diagnosis, and they weren't always that accommodating to the child's individual needs. So the second theme focused on the school journey, getting there. So participants said it was quite a hurdle just to get the child into the school, and then there were hurdles following that. So waiting lists, moving schools, and school fees were some of the challenges. Like some of the children that were in diapers were not allowed in until they progressed out of them, and some children weren't able to do that. So some children stayed in creche for longer than they should have been. Some found help and recommendation and support from their local clinics, their OTs and friends, and some were still looking for schooling options. So some of the participants were still unsatisfied with the special school they were at. The next sub-theme was growth and development. So most of the participants felt like their child had progressed and gained new skills and some independence, and they wanted the child to reach their own potential. So the expectations were generally based on the child's capabilities. But they also spoke about their personal growth and maturity beyond the schooling measures. And some of the participants worried about their child's future after school, especially those a little bit older and reaching the end of their schooling career. They were wondering what's next and what's the child going to do. So the school's operations is theme 3 and how the school functions. So there were 8 different schools in the study, and the schools ran a bit differently regarding logistics, class sizes and abilities, and additional in-house services. So some participants were against the mixed ability classes because they felt that their child was being held back from their potential. So if they were with a non-verbal classmate, but their child didn't struggle with speech, then they felt like their child wasn't progressing as they should. Some also felt that the classes were too big and the child did not get the individual attention that they needed. Some wanted more therapies and additional activities like sport, art, and music. There's also room for improvement in the communication between teachers and parents. So they wanted more feedback, more advice, especially if the child was nonverbal and couldn't tell them what they did at school. They wanted more feedback from the teachers. And the last sub-theme is it's a two-way street. So participants wanted guidance from the schooling staff regarding their children and what they can do to help their children meet their goals. But at the same time, they wanted the staff to recognize and value their own experience and expertise regarding their child and the genetic condition. So they wanted it to be a two-way street of communication and guidance. Participants felt that the teachers had more knowledge than they did sometimes. So it was important for the child to go to school and to be taught by someone with an education degree and training. Participants also felt like there was a lack of interest from the government and that they were not trying their best to improve the quality of education and care that children in special needs schools need and deserve. So looking at the genetic counselling aspect. So the study accentuated the ambiguity of where genetic counsellors fit into the team. So in summary, there are a few areas where the role of genetic counsellors is unclear and could be studied further. So our referrals to to support services like psychologists, physiotherapists, and OTs that help with school placement. Educating the schooling staff on genetic conditions to increase awareness and understanding. We understand that not every teacher can be an expert on every condition, but just a general background as to what additional concerns there might be with the children. Patient advocacy with regards to special needs schools. What can they ask for? What do they need? Do genetic counsellors know enough about special needs education and the schooling system in South Africa? And the balance of involvement and overstepping into other professions. And finally, implications for future research. So there are possibilities for pilot projects that could improve special needs education, like introducing additional classes, so music, sport, and computers, so let children experience other things and see if they prefer or enjoy those things. There's also a gap in what happens after school, where a training program could be implemented to help teach young adults and to assist with employment after school if possible. And these are just two examples that participants gave and I thought a bit more about. So lastly, I just want to say thank you to all the participants, to my supervisors, and are there any questions?
Great, thank you, Sinead. Does anyone have any questions for Sinead? In the meantime, Sinead, I just want to make a comment. I think that it is really important to have some type of genetic basis or understanding, you know, for these teachers, because it is challenging when you don't really know what to expect from various conditions. Do you think things like information or resources would be more helpful than doing in-person kind of communication, or what was your thoughts?
You know, I think maybe a mixture of both. There are a lot of special needs schools in Cape Town and I'm sure across the country. So reaching all of them might be a bit difficult, but maybe even going to some of the training institutes when they're learning and starting from there and yeah, just trying to get the word out there.
Okay, Nikita.
Thanks, Monica. Thanks for that presentation, Shade. It's good to hear your findings. I think it was in your first theme, in your second sub-theme, you spoke about, I think the bottom point was that some teachers didn't understand the child's specific needs. Was that mainly in mainstream schools, or was that also in schools for learners with special educational needs?
Thanks, Nikita. So it was actually in both. So the teachers don't always understand, you know, that there's limitations when you have multiple challenges, and that they weren't always accommodating in terms of like when they were sick a lot, when they had surgeries, you know, and falling behind because of that. They weren't always very understanding.
Thank you, Dina.
Nice presentation, Sinead. I just wanted to ask, you said that there's maybe a lack of knowledge with genetic counsellors on how special needs education operates, etc. in South Africa. How do you propose that as a community we improve that knowledge?
Thanks, Dina. I also think maybe it's, again, like that two-way street of the educators also feeding back to us about the processes and also explaining their limitations, right? Because we know that especially government schools are also under-researched. So coming to a sort of middle ground on what they can expect from us and what we can expect from them regarding students. Yeah.
Great, thanks, Sinead. Definitely scope to push this a bit further and get more involved. Well done, thank you. We're going to move on to Tasman Scriven now, who is presenting on genetic testing for inherited cancers in patients within the private healthcare sector of South Africa. Go ahead, Taz.
Good afternoon. I just want to put everything in order. Can you see my slides? Can you see my face? Can you hear me?
Yes.
Okay, so for those who don't know me, my name is Tasman Scriven. I'm one of the interns at the NHLS in Braamfontein, Johannesburg. I am presenting a component of my research project, which is titled Genetic Testing for Inherited Cancers within the Private Healthcare Sector of South Africa. I just want to minimize my camera. Okay, so my supervisors were Dr. Shirley McCauley and Ms. Mary Ann Gomes. So just to give some background, we know that most cancers are sporadic. So they occur for unknown reasons, usually a combination of genetic and environmental factors. However, about 13.5% of cancers are inherited, which means that they are caused by germline mutations in cancer susceptibility genes that are passed on from one generation to the next generation. So as many of you would know, the role of the genetic counselor is to determine the likelihood of an individual or a family having an inherited cancer syndrome. And we look at certain clues that characterize inherited cancer syndrome. This would be the early age of onset, so before 50 years of age for breast and colon cancer, the presence of bilateral cancers, linked cancers in a family, 3 or more generations affected, the presence of rare cancers such as male breast cancer, as well as descent from a high-risk ethnic group. So in South Africa, that would be the Ashkenazi Jewish and the Afrikaner populations. So anyone who has any of these clinical clues, it would be important that they're referred for genetic counselling because they would benefit from genetic testing. So in the past, genetic testing was predominantly done by single gene testing, so sequencing 1 or 2 genes at a time, and also targeted testing of common mutations. However, with increasing knowledge and expanding technology, we can now utilize multi-gene panels. And multi-gene panels have the ability to simultaneously test multiple genes associated with a predisposition of cancer. And so you have an increase in gene coverage, affordability, as well as accessibility. We know that about 16% of the South African population has access to private medical aid, and those that have private medical aid possibly are more likely to be able to afford local and international genetic testing in the form of gene panels. So at the time at which the study was undertaken, local laboratories offered gene panels that would probably include about 9 to 10 genes and were about 11,000 Rand. And these were sometimes covered by medical aid, depending on the medical aid scheme, as well as the tier in which the patient was in. However, international gene panels included about 80 genes and were only about $250 or 4,500 Rand, but they were not covered by medical aid. So why is genetic testing so important? So when an individual knows that they have an inherited cancer syndrome, they are able to understand and manage their risks. So they can increase surveillance and screening. They can have treatment strategies such as precision medicine. They can have preventative and risk-reducing surgeries. And they can also use these results for reproductive decision-making. So these strategies can also be extended to their at-risk relatives in the form of predictive testing. So predictive testing is the process whereby at-risk relatives of an individual with a confirmed germline mutation can also have genetic testing so as to refine their own risks. So the aim of my study was to provide an insight into the utilization of genetic counselling and the uptake of genetic testing by patients seen for inherited cancer through the Division of Human Genetics at the NHLS and VITS. So in order to do so, my methods were as follows. So my study population included private patients who were over or 18 years of age or older than 18 years, who were seen for a genetic counselling consultation between 2015 and 2020 for a personal and or a family history of cancer. This was a retrospective file review, and so patient records were used to extract certain data, such as the demographic information and the types of cancers present, genetic testing that was performed and the results of the genetic testing, as well as the uptake of predictive testing among at-risk family members. In terms of my data analyses, I used the Excel statistical analysis application. Descriptive statistics was used to summarize the data, and a statistical significance was assumed at a p-value that was less than 0.05. So moving on to my results and my discussion. So 290 patients were included in the study, and the majority of the patients, so 83.4% of the patients were female. And this is consistent with other studies that state that women are more likely to be involved in determining their risks of having an inherited cancer syndrome. And also there may be a misconception that HBOCS or mutations in the BRCA gene causes cancer, but only in females. It was seen that there was a very small number of Black participants in the study, so only about 5.5%. And there may be 2 reasons for this. One is that the founder populations in South Africa, so the Ashkenazi Jewish and Afrikaner populations, are predominantly Caucasian, and also because private medical aid and therefore private healthcare is skewed towards the Caucasian population. So in terms of the cancer diagnoses, the most amount of cancers was breast cancer, and this is consistent with the recent Cancer statistics in South Africa that state that breast cancer is the most common malignancy among women in South Africa. So a total of 206 to 290 patients, or 71% of patients, pursued genetic testing, which showed that there was a high uptake of genetic testing within the study population. And there was also, over the 6-year period of the study, there was also a shift in the landscape of genetic testing in South Africa. So previously, so before 2019, the majority of genetic testing was done at local laboratories. However, from 2019 onwards, it was done internationally. And this is because majority of the tests were done by Invitae. So we know that Invitae is a US-based lab that offers gene panels offered gene panels for $250, as well as offered free predictive testing for at-risk relatives. And so you can imagine that's why it was so popular from then. You can also see that there is a decrease in the amount of genetic tests in 2020, and this is because of the COVID-19 pandemic. So we saw less patients then, and also less tests were requested. So in terms of the genetic test results, a germline genetic mutation was detected in 50 of the 200 patients who pursued genetic testing, so about 24.3%, and 72% of these mutations were in the BRCA gene, and 55 of these BRCA mutations were the Ashkenazi and Afrikaner founder mutations. And so this then had implications for family members who could then have predictive testing. However, the uptake of predictive testing among relatives was actually quite low. So only about 36% of at-risk relatives came for genetic counseling to refine their risks. And it was seen that more individuals did not pursue testing than those that did. So a p-value that was less than 0.05. And this may be because sharing genetic test results with family members may be quite difficult, maybe due to geographic barriers, strained familial relationships, family culture, as well as fear and anxiety associated with the results. However, this study only looked at a 6-year period, and so family members may still come for genetic testing in the future, or may have already done so at a different center. And so this is one of the limitations of my research, which is explained over here. So family members may still come for predictive testing in the future. There are also some other limitations. So the study population was not an accurate representation of all individuals within the private healthcare sector, and the findings of the study cannot be extrapolated to the rest of the general South African population. The data collection was dependent on the record keeping of the counsellor, and also what the patient shared with the counsellor, and so there may have been recall bias. So what does this mean in the future? What are some future research recommendations? So we could conduct a similar study at another center. We can also repeat the same study, but in 5 years' time. So we all know that Invitae has recently changed its pricing and its policy. And so how would this change impact the findings of this result? Would we get something similar, or would we get something different? We could also perform qualitative studies. So first, to provide insight into why individuals accept and decline genetic testing, especially for their at-risk relatives. And we can also do a study that would provide insights into the perceptions of medical aid representatives on genetic testing, and whether they are aware of the competition that local laboratories are currently facing. We could also do a cost analysis study in which we would take the cost of genetic counseling, testing, and the following management, like the surveillance, the screening, and the preventative surgeries, and then compare it to the long-term management of a cancer diagnosis. So in conclusion, what have I learned, and what does all this mean? So there's a high uptake of genetic testing within the study population. The patients have a high interest in genetic testing, and they prefer the international option. The majority of mutations were found in the BRCA genes, and 55% of these mutations were the common founder mutations. There was also a low uptake of predictive testing among at-risk relatives. And what can we do to address this? So I know that a lot of members in this community are actively engaging with medical aids in order to get genetic testing covered by medical aid. And so I really want to publish this research as soon as possible so as to provide additional evidence to medical aid teams to highlight the benefits of genetic testing. Just to finish off my acknowledgements, I'd like to acknowledge my supervisors, Dr. Shelley McCauley and Ms. Marianne Gomes, as well as my colleagues at the NHLS and BITS. Thank you.
Well done, Taz. Does anybody have any questions for Tasman? Some comments coming in from Merlin. Merlin saying excellent job.
One supporter for everyone.
Nikita's got a hand up.
Sorry, I put the wrong emoji to start and I don't know how to take it down. Okay, I've got it off. Okay. Tasman, thanks so much for showing us that part of your research. I have 2 questions, if you don't mind. If you don't mind indulging me, you tweaked my interest when you said this is only part of your research. What else did you do?
So I looked at risk assessments. So I'm quite passionate about like online risk assessments, so CAN, risk, and PREM. And I looked to see the risk assessments that we give our patients, so the low, moderate, high, or in between, what's actually more accurate? Is it ours, or is it these risk assessments that are available online, which are usually based on Caucasian populations in Europe and America, not really based in South African or African context. And so I wanted to know which one's actually more accurate. And that we found that actually it's the online ones, but as in compared to ours, but actually this would make sense because this is also a private population, majority are Caucasian, majority are Ashkenazi, Jewish, Afrikaner population. So it wasn't so much of a surprise, but it was still very interesting to have done that. So I do want to present that at a later stage, but this is the first part, so wait for part 2.
Thank you, Tasman. That's one of my huge interest areas, and I think the others there that know me will tell you. So that's very interesting. The other part that I wanted to ask was around the uptake of predictive testing. We actually, we're just presenting an audit soon at Grooteskier about, and we just looked at our uptake as well. And it was interesting because we found that, so I was wondering if you could tell me your stats in a different way. So you said you had, of those that were eligible for family testing, it was around 36% presented, yes. But how many families presented, if that makes sense? I don't know. I think so if you know what I'm trying to ask you.
It would also be, it would be dependent on the family, whether the family is very interested versus the family is not very interested, or is it in terms of like bits and bobs of different families. So I think that's a great question. I think I might have to go back to my spreadsheets and kind of separate them, but I think it's a good comment to make. And it would be very interesting to see if it's a distribution among families or if it's a few families and what are the characteristics of the families. Also, if it's 100% of a family, but the family only has two sisters versus a family that's 10 brothers, 10 sisters, and only 2 came. So I think that's, it's definitely worth looking into.
I definitely think you should look at that if you're going to present it again. We had just out of interest, a 42% or 46% family pickup rate. So 42% of families showed up. Just thought I'd let you know.
Okay.
Thanks. I'll stop monopolizing.
Self-promotion is welcome here. Tina, I don't know if your hand's up on purpose or...
Hand is up, sorry. Can you hear me? Yes.
Yeah.
Nikita kind of asked or you've answered some of my questions, or a bit of the question by answering Nikita. I was interested in the testing that you offered in terms of roles, because, and what does that mean, having this pickup of 55% with founders? How does that affect going forward in terms of selection criteria for testing. And then I want to be controversial and say to you, what do you think about sending all our samples to Invitae and not growing our own testing?
Yeah, so I noticed that 55% is right in the middle. And so you kind of have this, like, is sending the samples for genetic testing overseas really worth it if the majority, well, if half of those are going to be found in mutations? But I think it's important to note that at the time of the study, it was a cheaper option. So about, it was half price, and it was also the free cascade testing. And so although it may be more beneficial to have done it here and to grow our own local genetic testing, I think the local labs also need to compete with international labs if that's the case. Yeah.
Yeah, it's a hard one, hey, because what we
It is a
want
hard one.
our patients. So, you know, as a counselor, you will choose the best, cheapest option with the best answer. But at the same time, you know, or taking all the samples or all the testing elsewhere, our own labs are not growing. And we don't.
And I think, and to reduce the cost, we would need more samples to come in, so a greater number, to make it more cost effective, and also to have more people analyzing the data and more, more technology. And so that's kind of where we also need to, that's what we need in order to catch up with Invitae. But we also don't know how this new policy is going to change the landscape. So it may be different in a year or 2 or 5. So we'll see.
Yeah, you can do this again in 5 years and tell us what you find.
Yes, absolutely.
Yeah, I guess it's also, you know, there was an overall benefit of the cascade testing, like you said, Taz. So, you know, if you can sort of hit many birds with one stone, rather go that way.
Yeah. And also it's 55% of, you don't know there's also 45% that may be other mutations, and you don't want to miss those by just doing founder mutation targeted testing.
Yeah, because then it's an additional cost over and above.
Exactly. You would have to do further testing in any case.
Anyway,
and a negative wouldn't be a true negative. Okay, I'm done.
Claire, if you don't mind just sending your question in the chat. We are going a little bit over time, so I want to get started on Dina's presentation, and Taz will respond to you in the chat if that's okay. Dina's presenting on individuals at risk for SCA, the impact, perceptions, and decision regarding genetic testing.
Okay, I just want to check you can see my slides. Can you hear me? Okay. Good afternoon, fellow genetic counselors and other healthcare professionals attending today. My name is Dina Lloyd, for those of you who don't know me, and I'm a genetic counselor trained at UCT. Today, I will be presenting on some of my research findings from my master's research project entitled Individuals at Risk for SCA, Impacts, Perceptions, and Decisions Regarding Genetic Testing. Okay, sorry. So to give a bit of a background, the spinocerebellar ataxias are a group of more than 40 genetically different ataxia subtypes, all characterized by the progressive incoordination of movement caused by atrophy of the cerebellum. Since the introduction of pre-symptomatic testing for spinocerebellar ataxia in South Africa, no research has explored the impact, perception, or acceptance of this testing within this diverse population. And despite the high frequencies of SCA in South Africa, the uptake of testing by those at risk has been noted to be lower than that seen internationally. Therefore, this research project sought to understand these low levels of utilization by exploring the perceptions of those at risk towards pre-symptomatic testing. Okay. Due to the sensitivity and difficulty of accessing this population, 3 different sampling methods were utilized to recruit participants. Thereafter, in-depth, semi-structured interviews were conducted with 6 at-risk individuals. The interviews were then thematically transcribed verbatim and thematically analyzed using the 6-phase approach proposed by Braun and Clark in their 2006 paper. This is illustrated in the figure at the bottom of this slide. Through in-depth analysis, 4 themes emerged from the data, represented visually here. As illustrated, the themes are connected as the participants' experiences of the condition had a major impact on their perceptions and decisions. We will explore each of these themes separately now. Theme 1, caregiving. The significant and long-lasting burdens faced both physically and emotionally by the affected individual and their relatives was highlighted in this research, with the caregivers being noted as bearing majority of the burdens. This included large financial burdens associated with loss of income of both the caregiver and the affected individual, and treatment costs and transport. Additionally, the experience of affected individuals being abandoned emerged frequently. This experience was often associated with the participants' own fear of being abandoned in the future. The research also highlighted how caregivers often felt hopeless due to a lack of treatment option available for the affected individual, which often led to them actively searching for hope by taking relatives to healthcare specialists, searching for clinical trials, and trying alternative medications. In particular, alternative medications came out strongly in the research, with participants feeling that it often helped their affected relative more than the traditional treatment options, although this cannot be verified with the current research. Theme 2, relationships. It was expressed that the broader community had generally been supportive. However, in some instances there had been stigma and judgment reported, especially with community members thinking that their relatives were intoxicated due to their symptoms. One of the most common experiences described was a general lack of understanding of the condition in the family and in the community. This lack of understanding was what most often led to stigmatization and abandonment of the affected individual. Additionally, the presence of the condition had affected communication both within the family and the broader community, with there often being secrecy surrounding the condition in the family especially. Additionally, several aspects of SCA were described to cause conflict and the breakdown of relationships. The most common cause of conflict, which was different to what was found in Huntington's disease, was that it was linked to who would take on the caregiving role and the quality of care that was actually being provided. So theme 3, being at risk. Living with the uncertainty of developing SCA was often described by the participants as emotionally overwhelming. In the table, the main fears to emerge in the data are shown. The participants' experiences and fears resulted in behaviors like selective disclosure to the general community and loved ones, and self-isolation. While selective disclosure was common amongst all the participants, self-isolation was most common amongst caregivers. Additionally, the participants' anxiety was often age-related and led to behaviors like symptom watching in themselves and their relatives. Risk perception. All of the participants in the study, apart from Noah, had attended at least one genetic counselling session. And therefore, they should have had their risk explained to them at some point. Although what the findings were that although they were aware that they were at risk of inheriting spinocerebellar ataxia, they all expressed uncertainty and confusion about their exact personal risk. In fact, their risk perception was often based on their personal beliefs of inheritance and often influenced by their current age, compared to the average age of onset of symptoms seen in their relatives. Most described only starting to worry about their risks and considering pre-symptomatic testing when they got close to the average age of onset seen in their family. Theme 4, pre-symptomatic testing perceptions. The decision to undergo pre-symptomatic testing was described as complex and emotional. At-risk individuals' perceptions and fears were often related to their own experiences. And all of the participants expressed positive perceptions of and interest in pre-symptomatic testing. However, interestingly, all but one had delayed going for testing to date. This was attributed to, in part, the inflexibility of the pre-symptomatic testing protocol, which was seen as a deterrent by some. In particular, the length and perceived expense and need for a support partner were seen as obstacles to following through in the testing. The participants' main reason, however, for delaying testing was due to a fear of the major consequences of the result. As such, the current underutilization of pre-symptomatic testing in South Africa was found to be due to the at-risk individual's fears of the results and its perceived consequences, rather than a negative perception of pre-symptomatic testing. As such, genetic counselors are encouraged to focus their efforts on counseling the individual through their fears, as opposed to primarily offering pre-symptomatic testing. This research highlighted the need for genetic counselors to be aware of the complexity of the decision to undergo testing, and to understand that for some at-risk individuals, choosing not to go for testing can be a healthy coping strategy. This is consistent with previous research in Huntington's disease. Although these findings contribute to our understanding of this previously studied population, they cannot be extrapolated to the entire South African at-risk population due to the small sample size of the study. So further research is encouraged. The knowledge, however, may assist in improving the pre-symptomatic process by providing insight into the population's experiences and perspectives. Thus, it is recommended that future studies explore ways that genetic counselling sessions and the pre-symptomatic testing process could be altered to incorporate this knowledge. Additionally, it is proposed that future research explore more adaptable solutions for personalising the pre-symptomatic testing protocol. So a special thank you to my supervisor, Tina Wessels, and thank you for your time.
Great, thank you, Dina.
Okay.
Does anybody have any questions for Dina about her presentation? Dina, I have just one question. The people that you interviewed, was there any sort of correlation between when you interviewed them and how recently the diagnosis had been made in the family? Because you wonder, you know, whether it was all very new and overwhelming and so they perceived their risks differently because it was all new and overwhelming, or was it just something that was there all the time?
So it was actually a very big topic in terms of when they'd found out and how recent it was and things like that. But because it was such a small population group, it's hard to make correlations. But majority had found out and knew. One of the factors that we ruled out is they had to know about their risk going into this research study. And most of them had found out way before the research study and still hadn't come forward for genetic testing.
Okay. Yeah, I guess and perhaps the need for additional genetic counselling consultations after those first few, because it is just like, it's so overwhelming they don't actually remember or retain the information in the way that we expect them to.
One of the recommendations would be to actually follow up and do it, or to give it in more concise chunks rather than a huge overwhelming amount of information all at once. But that's obviously a limit in terms of getting them back and if they've traveled for this appointment and things like that. So it's all the type of thing that should be looked at in the future and how we can adapt it to help. Yeah.
Great. Nikita?
I was actually going to ask a very similar question to what you've sort of just said, Dina, in terms of your recommendations about, you know, I mean, it came to me thinking, you know, do we do family sessions, or, you know, how do we make sure that we address these needs that you highlighted in the conclusions? Because I think we all know that, you know, not PT isn't for everyone, but how do we make sure that these fears or their family needs are addressed?
Yes. So, I mean, that is a very difficult question and something that we really need to figure out. But I think individual sessions would be more effective because there is individual concerns and worries that were very clear within it. And it's a very complex topic. That's what I found when doing the research is, so there's so many layers to the problems and the experiences that these different individuals face and what affects how they feel about the testing and going forward. But the most important thing I think is to stop focusing on this is what we can offer you and more how has it been, what are your concerns, how can we help you understand what's going to happen, things like that.
So focus more on the coping.
Yeah, because it is a huge very difficult thing to cope with. You can imagine having this hanging over your head most of your life.
And one last question. I mean, so I think often when patients come to clinics, they usually only come with one caregiver. So do we need to actively encourage the other people in the family to come forward, or how do you recommend we do that?
It's also, that's one of the reasons why I had such a limited sample size, is getting access to this population is extremely difficult. I didn't talk about it in the slides, but in the 4 months that I attended clinic, not one affected individual actually attended their sessions. But the third sampling method was to ask the participants if they could refer any other people in their family. And what came out is there's huge amounts of family conflict and different dysfunctional family dynamics that make it very difficult to communicate between different relatives and to get the information out there. There's also large amounts of secrecy within the family. What we found is most of the participants only found out as adults. Their parents tend to keep it a secret, which also causes a bit of resentment. So there's a whole lot going on within the community. So I'm not sure how we would get information out, but I think it has to start with a general awareness of the condition, because there's not even a spinocerebellar ataxia support group. At one time thought maybe getting them to join Huntington's would help, but I don't know if that's too confusing a dynamic. So I think maybe starting with just a general population awareness, also at the clinic and things like that. I don't know how we would get the information out of there. Yeah.
Thanks, Dina. I think that sounds like a good suggestion regarding the support group.
Okay, great. We're going to move on to Zandi. So Zandi's presenting an audit of patients seen by genetic counselors for a history of recurrent miscarriages.
Okay. Thanks, Monica. I just want to make sure if you can hear me.
We can, and we can see your slides.
Cool. Right. Good afternoon, everyone. My name is Zandi Goliath, and I'm a second-year genetic counseling intern at the Division of Human Genetics at the NHLS and the University of the Witwatersrand. So as Monica has mentioned, the title of my research is an audit of patients seen by genetic counselors for a history of recurrent miscarriages. And my supervisors were Dr. Sheila Macaulay, Alzette Naba, as well as Professor Henny Lombard. The recurrent miscarriages are defined as 3 or more early consecutive miscarriages, and the common causes of recurrent miscarriages include endocrinopathies such as thyroid diseases, vitamin D deficiencies, or prolactin disorders. Antiphospholipid syndrome is a most clearly defined autoimmune disorder that's characterized by thrombotic episodes and pregnancy complications. Uterine structural abnormalities can be either classified as congenital or acquired, where acquired refers to fibroids or polyps. Parental chromosomal abnormalities, specifically balanced translocations, account for 2 to 5% of recurrent miscarriages. And what's important to note is that 50% of recurrent miscarriages happen for an unexplained reason. Caffeine, alcohol, smoking, and increased BMI are associated with spontaneous pregnancy losses, but have been difficult to correlate to recurrent miscarriages. Pregnancy is a very defining event for women, and provides them with the identity of being a mother. Miscarriages have devastating impacts on couples that may have long-lasting effects. The loss of a pregnancy has shown to affect women and men differently, where men often express feelings of frustration, lack of control, guilt, or rage, and women often express or show declined self-worth and distorted body image. The role of genetic counselors in managing patients with recurrent miscarriages is to address the psychosocial needs that couples present with and to help determine a potential genetic cause for the recurrent miscarriages. The topic of recurrent miscarriages has been understudied in the South African context, and only 2 studies have looked at recurrent miscarriages in South Africa. The first paper looked at the association between medical conditions, BMI, and recurrent miscarriages. And the second paper was a literature review that provides evidence-based approach to recurrent miscarriages. So the aim of my research was to perform an audit of patients seen for recurrent miscarriages through the genetic clinics of the Division of Human Genetics at the NHLS and WITS. And the research questions that I developed were: what investigations were performed on patients with a history of recurrent miscarriages prior to being referred to genetics? And what proportion of patients and their partners underwent karyotyping and were found to be balanced translocation carriers? So looking at the methodology, we were able to obtain ethical clearance from the University of the Witwatersrand. The study was a retrospective file review that used quantitative research methods. The study comprised of files from patients that were seen at the genetic clinics for recurrent miscarriages and or poor obstetric history. We looked at 101 files for over a period of 11 years between 2011 and 2021. A data collection sheet was designed to be able to collect specific patient details that were recorded in the file. And the study made use of basic descriptive statistics that were analyzed using Microsoft Excel. So looking at the results, the demographics, we saw a mean age at the time of referral of 34.5 years. And what's important to note is that 47.5% of our patients were of advanced maternal age, and around half of the patients were pregnant at the time of referral. So looking at the investigations that were performed prior to being referred to genetics, we saw that over half of the patients underwent autoimmune testing, and several of the patients had abnormal autoimmune testing results, however, weren't referred with a confirmed diagnosis of an autoimmune disorder. Screening for anatomical uterine abnormalities was quite poor, with only 26.7% of the patients having had screening, and a large proportion of those abnormalities that were found were fibroids. Just over half of the patients had thyroid screening, and a relatively small amount of patients had abnormal TSH results. So this pie chart is a presentation of the investigations that were performed prior to the patients being referred for genetics. So what we're looking at is patients that had no investigations performed before being referred to patients that had all the recommended investigations performed. And what's important to note is that only 14% of the patients had all the recommended investigations performed prior to being referred to genetics. And 22% of the patients had no investigations prior to being referred to genetics. Looking at the genetic testing that was performed, of the 101 patients that were referred for genetic counseling, only 43.6% of the patients underwent karyotyping, and only one of those patients had an abnormal karyotype result of a mosaic trisomy 17. The male partners of the patients were also offered karyotyping, and only 26.7% of the paternal karyotypes were performed, and none yielded abnormal results. So this is the first study to report on the investigative practices of recurrent miscarriages in South Africa, in Johannesburg, South Africa. The lack of local guidelines results in the adoption of international guidelines that might not be appropriate in under-resourced clinical settings in South Africa. According to the Royal College of Obstetricians and Gynecologists guidelines, couples with three or more miscarriages that have been thoroughly worked up require a referral to genetics. However, this was not what we observed in our study. We saw that only 14% of our patients had the recommended investigations performed, and 22 of the patients had no investigations performed prior to being referred to genetics. As balanced translocations only account for a small percentage of recurrent miscarriages, investigating genetic causes as first-line investigation is a waste of resources. Parental karyotyping is recommended for couples who experience recurrent miscarriages and who have no other identifiable cause for their miscarriages. 43.6% of our patients underwent karyotyping. Almost half of the patients were advanced maternal age at the time of referral, and 49.5% of our patients were pregnant at the time of referral. So it's likely that the patients who did not undergo karyotyping were offered invasive testing for advanced maternal age. Therefore, karyotyping was not investigated. Only 26.7% of the male participants underwent karyotyping. And in a study that looked at male partners' views of involvement in maternal health care services in South Africa, men view maternal health as a woman's domain. And this was largely influenced by their culture, which doesn't promote male involvement. And other males reported that their employment status affected their ability to participate in their partner's care. One patient had an abnormal karyotype of mosaic trisomy 17, which is a rare trisomy that is normally or mostly detected prenatally. A full trisomy 17 has not been reported in live births. No balanced translocation was detected in the 43.6% of the patients that were tested, and it might be possible that in the 56.4% of the patients that weren't tested, we might have found a balanced translocation carrier. So the limitations of our study: maternal illnesses, weight, and lifestyle factors were not taken into consideration, and this study was not representative of South Africa as a whole. For the recommendations, only 14% of the female participants in the study had all the recommended investigations performed. This could be related to the lack of local guidelines that would assist in providing a framework for the management of recurrent miscarriages in our local setting. Chromosomal analysis costs compared to other investigations is relatively expensive. So it might be more cost effective to extensively investigate other causes for recurrent miscarriages instead of prioritizing karyotyping, which yields low results. In conclusion, our study found that no balanced translocations in any of the patients, and this supports what is found in literature about balanced translocations accounting for a small percentage of patients with recurrent miscarriages. Therefore, genetic testing should not be the first-line investigation for recurrent miscarriages, as it is a waste of resources. We also found that women are very poorly investigated for recurrent miscarriages, which could be frustrating and can cause strain in our patients that don't receive answers. Implementing a multidisciplinary approach in managing recurrent miscarriages in our setting may help in investigating women and their partners thoroughly. I'd like to thank my supervisors as well as the clinical and counseling division of the Human Genetics. Thank you.
Thanks, Zandi. Does anybody have any questions for Zandi? Taz has got a lot of questions going on in the chat. Nikita?
Hey, Zandi, it's nice to have your experience with that, actually. We haven't done an audit of our services, but my thought is it's possibly very similar results to you. I had a question. It was so interesting to see all the investigations and results that had done prior to referral to genetics. But I was quite interested to see that there was still a referral to genetics despite some of those females actually having an underlying cause that was determined on the underlying tests. Can you comment a little bit further about that, why they still got referred?
I think I'm not sure. I really can't say why the doctors didn't really look at the investigations and the abnormalities and see whether they needed to repeat testing to confirm a diagnosis in the patients. But I think it's just a lack of a framework in our fetal medicine units in being able to know which patients to refer and what they need to be investigated for them to be tested.
Was it sort of like an automatic knee-jerk? I think we also experience where it's someone that's pregnant, 3 miscarriages must go to genetics. Did it sort of seem like that?
Definitely, that's how it works. Yeah.
Okay, thank you.
Okay, does anyone else have any other questions? Well done, Zandi. It was a big feat to get through all of those documents and paperwork. Okay, if anybody doesn't have any other questions, then we're gonna move on. Next, we have Sydney Francois. This is a mouthful, who is investigating the ethical views guiding decisions to offer late termination of pregnancy amongst healthcare professionals involved in termination of pregnancy decisions in the Western Cape.
Thanks, Monica. Just want to move things around here a little bit. Can everyone see my screen and hear me clearly?
Yep.
Okay, great. So thanks for that introduction. For those who don't know me, my name is Sydney Francois. I completed my master's at UCT, and today I'll be giving you a little bit of insight into a couple of the findings from my master's research project, where I focused on investigating the views of fetal medicine practitioners and how they make decisions about late termination of pregnancy within the Western Cape, South Africa. So, sorry, my slides aren't progressing. There we go. So a little bit of background. As we know, the Choice on Termination of Pregnancy Act in South Africa allows for termination of pregnancy after 20 weeks. And from here on out, I'll refer to this as late termination of pregnancy in specific circumstances. So such as when the mother's life is endangered, when there's a severe malformation of the fetus, or when there's a risk of injury to the fetus. Studies conducted in other countries have found that terms such as severe malformation and injury are ambiguous, and this leaves fetal medicine practitioners with the decision of whether or not they should offer late termination of pregnancy. However, within South Africa, there's been very little research done on this topic, and our study aimed to better understand fetal medicine practitioners' views on late termination of pregnancy and how they make these decisions within the Western Cape. So in order to do this, we conducted an in-depth interview study based on interpretive phenomenological analysis with 6 fetal medicine practitioners from within both the state and private healthcare sector. So the participants who were included were fetal medicine specialists, medical geneticists, obstetricians, and gynecologists, all who had a direct involvement in the late termination of pregnancy decision-making. So one of the important studies, or the first important study that we found, was that participants felt that the Choice on Termination of Pregnancy Act was based on the concept of gradualism, which says that the fetus has been granted more protection in the law as gestation advances. However, they felt that as fetal development is continuous, that there should be various stages based on gestation where termination should be permitted for various degrees of severity. So, for example, although the Choice on Termination of Pregnancy Act states that TOP after 20 weeks is permitted for severe malformation of the fetus, participants in our study felt that TOP between 20 and 24 weeks could be considered for less severe fetal conditions, such as a confirmed diagnosis of Down syndrome. But TOP after 24 weeks should only be permitted in significantly severe fetal conditions. The second finding was that participants felt that the primary purpose of late termination of pregnancy should be to prevent the suffering of a child born with a severe disability. And they felt that certain criteria needed to be met in order for a condition to be considered a severe malformation. The first of this was that it would have a profound negative impact on the functioning and quality of life of the future child. That it would lead to long-term suffering and disability for the child, and also that it would be an untreatable condition. So they felt quite strongly that not all disability was equal, and refuted the idea that late termination of pregnancy be offered to prevent the birth of a child who would be imperfect in the parent's eyes. So, for example, an isolated cleft palate. Because of this, they felt that decision-making was more difficult, particularly when it came to instances where the severity of the prognosis was uncertain. We found that participants in our study were aware of their own subjectivity when it came to decision-making and its role in the decisions that they made. And due to this, they believed that all decisions should be made by multidisciplinary teams in order to promote objectivity and consistency. They also felt that these multidisciplinary team discussions allowed for experts from different specialties to weigh in on the prognosis, so such as neonatologists and pediatric cardiologists, and that the moral burden of these difficult decisions was also shared when it was based on a consensus. So overall, participants felt that the terms severe malformation and injury, which are used in the Choice on Termination of Pregnancy Act, are vague and open to interpretation. And this caused concerns with regards to the subjectivity in decision-making and a lack of regulation, which they felt could lead to patients being offered different choices depending on the hospital that they attended and even the doctor that they were seen by. So in order to avoid this, they suggested that a national guideline should be developed to ensure consistency in late termination provision across the country. And they felt that this guideline needed to be developed based on consensus of the wider fetal medicine community. However, they did warn against a prescriptive list of conditions due to the complex nature of many fetal abnormalities, and felt that a guideline should streamline decision-making, but should not replace multidisciplinary team case-by-case discussions. So although this wasn't investigated within my study, I thought this was a great opportunity to discuss the applications of this research to genetic counselling practice and how it affects our field. So first, we rely on fetal medicine specialists to make decisions about whether or not termination of pregnancy should be offered. And this can create uncertainty in some cases where this isn't disclosed up front and we're not sure what would be offered to the patient. So although fetal medicine specialists are generally available to provide guidance on late termination of pregnancy, we know that sometimes they aren't available, and that without a concrete and comprehensive referral form, it is difficult for us to know what to do in cases that are not straightforward or that we don't deal with on a day-to-day basis. Secondly, when it comes to genetic testing results and prenatal genetic testing, certain genetic testing results, such as variants of uncertain significance, but also variants associated with incomplete penetrance or variable expressivity, may complicate the fetal medicine team decision-making around late termination of pregnancy, which is something that we should discuss with them up front prior to performing prenatal testing that may yield these results, such as a prenatal array. So the takeaway findings from the study are that participants felt that the current Choice on Termination of Pregnancy Act was open to interpretation regarding late termination of pregnancy, and that this could cause inconsistency in late termination of pregnancy provision across the country. In order to resolve this, they proposed the development of a national guideline for late termination of pregnancy. And these findings reflect findings conducted in other countries. The main limitation of the study, or the main limitations of the study, was that it was conducted on a small sample size of individuals who were likely to be interested in participating in the study, which meant that the results that we yielded didn't have any drastically or radically different opinions that were expressed. So going forward, inherently in qualitative research, there is always the bias of the researcher that is involved, that there is an individual on one side dealing with the data and interpreting that data with regards to, or on the backdrop of their own values, perceptions, and biases. Going forward, the recommendations of the study was that national late termination of pregnancy guidelines be developed to promote consistency nationwide. And we also suggest that this topic be investigated further on a larger sample size to understand the views of the fetal medicine community nationally. So thank you for everyone's time today, and a big thank you to GCSA and Next Biosciences for making this happen. And should you have any questions or comments that you'd like to make about my research, here are my contact details. I'd very much welcome any feedback. Thank you.
Thank you, Sydney. Well done. Anybody who knows Sydney knows this is her passion. So it's lovely to see research on this. Does anybody have any questions for Sydney? Tina?
There we go. Yes, we know Sydney is very passionate about the ethics of termination of pregnancy. Sydney, you were looking at 2 hospitals only.
Yeah.
And even in those 2 hospitals, they had different guidelines. Can you just, I mean, already you had a sample where the 2 hospitals were not dealing with the decisions in the same way. Can you just explain that a little bit?
So I think that's what prompted this research idea in the first place, was noticing a bit of an inconsistency between what was happening. And the more I looked into it, the more this became apparent. So actually, we only ended up recruiting participants from 1 state hospital, and then from within the private sector as well. So these 2 hospitals that you're referring to do have very different guidelines and different views on certain procedures associated with late termination of pregnancy, such as feticide. And I think that really made the point of why this research needs to be done. Firstly, I think a big thank you to the hospitals for establishing those guidelines, and to those fetal medicine teams who have taken the initiative to try and streamline their late termination of pregnancy process. However, I really do feel that a more national guideline needs to be implemented.
It really is difficult, and I was interested where you mentioned that uncertainty, and I think, you know, can you comment on the uncertainty of the diagnosis that we are making and how that makes it so difficult to have a standardized guideline or a list of conditions, because it really is difficult.
Yeah, absolutely. And I think, you know, within fetal medicine, you get certain anomalies that have varying degrees of severity. So, for example, your ventricular megalies or certain cardiac defects. And once you put together a few fetal anomalies, it compounds that even more. And it's difficult to know, firstly, is this associated with a specific genetic condition like a chromosome abnormality or single gene disorder? And it's difficult to pinpoint exactly what the prognosis of those conditions is without that kind of in-depth testing, which we know isn't practical to do single gene testing without a family history and a pregnancy. And I think this kind of plays into the idea that the guidelines need to not be prescriptive, that there are certain conditions, for example, a spina bifida. Whether you have a lower spina bifida or a higher spina bifida, there's going to be a different prognosis. Whether you have a spina bifida in conjunction with a cardiac defect, there's going to be a different prognosis. And so certain more complicated cases would need case-by-case discussion within the multidisciplinary team, but the cases that are more common would have guidelines associated with them that would streamline the decision-making. That answers your question.
Yes, and I'm just thinking that, you know, this is where the genetic counselor is so important to manage that uncertainty in that session with the patient, to actually be that go-between about with what they found on ultrasound and all the tests and the options, and deciding whether they continue or not. Interesting. Thanks, Sydney.
Thanks, Tina.
I think even things like, like you said, if someone gets a prenatal diagnosis of 22q, what do you do with that? Because some patients might be really severely affected and others might be okay for the most part. So it makes it difficult to decide on what to do.
No, absolutely. And I mean, we've seen it within our own units. I mean, I've had a case of a prenatal array which came out with a variant which had a very low penetrance and significant variable expressivity. And thankfully, the patients weren't considering termination of pregnancy prior to doing testing. They simply wanted more clarity. But I think if they had wanted termination of pregnancy, it would have been extremely complicated to navigate that.
Definitely. Makes our jobs all the more exciting. Thank you so much, Sydney. Just before we go on to our last speaker, it's really been so lovely. I've really enjoyed watching all of the presentations today. I am going to send a link for an attendance register, if everybody can just fill that out, particularly important for the CPD points. So if you're not interested in getting CPD points, don't worry about it, but we do need it for CPD points. Okay, so our last presenter, thank you for holding on, Angelique, is Angelique Diedrichs, and she's presenting on parental perspectives regarding the return of genomic findings in neurodevelopmental disorders, a South African study.
Thank you, Monica. I'm going to see if you guys can see my screen. Why am I struggling? Ah,
there we go.
Can you all see that?
Yeah.
Oh, let's go back. There we go. Okay, so I want to say good afternoon to the genetic counselling community and to every other health professional that's attending. I'd like to thank Genetic Counsellors of South Africa, the GCSA and Next Biosciences for giving me this opportunity to share my research with you. Today I'll be talking about my study, which Monica has already introduced, another mouthful just like Sydney's. We had the same supervisor. So today, like I said, I'll be talking about the parental perspectives regarding the return of genomic findings in neurodevelopmental disorders. My name's Angelique, for those of you that don't know me, and I'm a genetic counselor and medical scientist, and I'm currently working for internationally based companies, Agiomics and Counselomics, where Agiomics is a clinical laboratory performing genetic testing and tertiary analysis with a focus on precision medicine, and Counselomics is a genetic counselling service, and we work with an in-house team, multidisciplinary team of doctors, nurses, nutritionists, oncologists, and so forth. So to get started, we all know that genomics research on mental health conditions and neurodevelopmental disorders is gaining traction in South Africa, and there's a multitude of projects being conducted at UCT, such as the NeuroDev study and the H3 Africa Consortium. Now, my study formed part of a sub-study of the NeuroDev study, and it's just a bit of background on the NeuroDev study. It's a large-scale international collaborative study, which aims to map genetic variation amongst children with neurodevelopmental disorders by performing genotyping and exome sequencing on children aged 2 to 17 years old. So, with genomic research, one pertinent challenge remains, and it relates to what to do with research results that are relevant to the health of the participants. We know that with the exception of H3 Africa, feedback of findings guidelines, there are few policies and very little research that exists regarding the disclosure of these research results in South Africa. So this is an issue because it may be predictive of the participants' future health. It may impact on their reproductive choices and may have implications for other family members as well. It could also lead to difficulties for these individuals in obtaining health insurance in certain circumstances. And individuals may be exposed to stigmatization or ostracization by their family or society. And furthermore, it may place a burden on the research enterprise. However, it also does have the potential to foster partnerships, productive partnerships between researchers and participants, and also to support public understanding of the importance of research in healthcare, provide education regarding the complexity of genetic findings, and also offer more involvement for these participants in biomedical research. But key considerations are always in disclosing or returning genomic research results would be the pathogenicity and scientific evidence of these results, autonomy and consent of the patients, participant satisfaction, the context or setting in which the research is being conducted, and the importance of the researcher to wear an ethnocultural lens. Unfortunately, I don't have time to elaborate too much on that, but I think we all know the gist of that. So importantly for me as well, I wanted to find out if there was an opportunity for genetic counselors to actually impact on this field. So as such, my aim was to investigate parents' perspectives and preferences regarding the feedback process and the anticipated contributions of such findings. And also the results from the study was hoped to inform a returns policy for pertinent genomic research results for the NeuroDev study, and also to possibly be of a wider use for other genomic research being conducted at UCT. So I had three main research questions, and these were what participants understood about what they consented to, why they wanted positive research results, and how these results should be fed back to them. So I did purposive sampling through the NeuroDev study, as I mentioned, and I recruited the parents of the children with neurodevelopmental disorders. I used a pragmatic qualitative approach, and I conducted 12 semi-structured interviews with 17 participants. My interviews were recorded. My project ran from May to July 2019, and I obtained UCT HREC approval. These interviews were transcribed and imported into in vivo 12, and thematic analysis was employed to generate the codes. So in the interest of time, I will only briefly be touching on aspects relating to my themes. So in answering my first research question concerning participant understanding and their expectations and the reasons for partaking in research, I found that people want to know about findings that have preventable implications. Participants described two reasons for their participation in the NeuroDev study, namely altruism, where they're willing to go through great lengths to save others from the same fate. And research formed part of this altruistic act in that participants seemed to conceptualize it as the one thing they could do to make a difference by contributing to information and awareness about such conditions, and thus reducing or preventing these conditions from occurring. A second motivation was for personal and family benefits. Here, participants hoped that they would gain more information regarding neurodevelopmental disorders, which would result in the development of better strategies in managing neurodevelopmental disorders, could inform recurrence risks, and could offer them a chance to plan for their family's future. Generally, the return of results was seen by many as a point of access, either to information regarding their child's condition or concerning help with the management of their child. And this could all lead to the best chance in life for their child and could help reduce any uncertainty that they had. In this study, it was also evident that it may be important to consider the perceived value of a negative result and the meaning participants attribute to results in general, in addition to the assessments of clinical utility or medical actionability, as participants may classify these concepts differently to researchers. For instance, in my study, participants clearly described that negative results would be a valuable return for their participation in the NeuroDev study, and it would confirm that they themselves and researchers had done all they could to discover the cause. Informing my second research question regarding pertinent results and participants' expectations about the impact of these results, it was apparent that the majority of participants wanted results of clinical significance and not a data dump, which they would struggle to make sense of and which would have the potential to aggravate anxiety. Pertinent results could offer closure, bring personal acceptance, relief, and the ability to move on. There was a notable difference between participants whose children had a diagnosis and those who didn't. For those whose children were diagnosed with autism, participants felt that a pertinent result could improve management for their child and could inform of recurrence risks. For those whose child remained undiagnosed, a name for their child's condition could lead to defined management and treatment and guide them in conducting their own research. Whilst not the same as stigma, and I did not specifically probe experience of stigma in the study, feelings of guilt and self-blame relate to stigma in that caregivers often experience this stigma, this felt stigma, in numerous ways, namely through a lack of knowledge, judgment, lack of support, and rejection. These parents tend to internalize these feelings, blaming themselves for their child's condition, feeling responsible or guilty, and ultimately experiencing shame. There was some expectation that the return of results would impact on resolving feelings of guilt and sometimes self-blame, as many of these participants alluded to seeking confirmation or validation that they were not responsible. So as the one participant said, if it's something that is in his DNA, it's not something that comes from me, then I'm not going to be worried because I'm not going to feel guilty like I'm the cause of him being like that. I'm going to know that it naturally comes like that. But if it's going to come like something that he get from me, I'm going to feel guilty on the other side. Because even when I look at him suffering, or it's difficult to do something, I'm going to be like, you are like this because of me. My final research question regarding their preferences to feedback and what they want to know and when, as previously mentioned, a negative result was meaningful and it may be important to acknowledge this personal utility. Participant 12 said yes. I think that is as important. I think it's more for peace of mind and also it's just about us being included. Keep updated. A negative result is still a result. Participants gave diverse preferences concerning the results feedback process. However, overall, their perspectives were the desire for certainty over the cause and course of their child's condition, familiarity with the persons delivering the results, researcher transparency, and the call for respect and confidentiality from those feeding back the results and concerning the sharing of the results. They also had a need for study involvement throughout the research process. Another important consideration is that participants' expectations of receiving results from the study was influenced by the time since last contact with researchers, where a greater time lapse since contact seemed to lower any expectation of receiving results. So I had a couple of recommendations and I'll just briefly mention some. The first one would be a tiered consent model that, with options for which kinds of findings participants would like to receive. And this could be supported by a follow-up session describing what these results could mean and how they could use these results and whether it has the potential for clinical therapeutic benefits locally. And then this information need not be done at the same time as primary consent, and it could be group-based. Also, furthermore, it may be useful to discuss participant preferences regarding the timing of receiving information about results, and where they cannot be accommodated, reasons for this should be explained. A practical approach could include WhatsApp information or updates at their clinic visits. An interactive process may ensure participant understanding where the research can play an integrated role with the clinical interface. And given that participants find personal meaning in negative results, the absence of a positive pertinent result may also need to be communicated during the initial stages of consent, and any limitations should be openly communicated. And this could perhaps be done through a newsletter or an informative event. Last but not least, for me, genetic counselors can act to bridge this gap between researcher and participants by being available to address concerns and through following up with participants regarding the progress and stance of the research, and can in such manner meet the desires of the participant. I had a few study limitations where researcher influence is inevitable in qualitative research. There's always a possibility that data saturation was not reached, even though similar themes did emerge in my research. I'm a novice researcher, so certain cues or important concepts may have been missed or not explored initially. Certain aspects cannot be represented as I didn't obtain socio-demographic data. However, it was not particularly relevant to my study, although it is equally important. There were some difficulties in the interview and transcription processes because some of the couples or parents brought their children along to the interviews, and there was some background noise and the children were quite busy within the sessions. Purpose of sampling may mean that data may be skewed. My sample was small and it was narrowly tied for a particular condition, and couple interviews may also have influenced the responses of participants. I'd like to acknowledge the following people and projects. So this work was co-funded by the Genre Award, which forms part of H3 Africa Consortium and the Narrative Study. I'd like to give a special thanks to my supervisors, Jantina de Vries, Kirsten Donald, and Nikita Lang. Thank you for your ongoing support and advice. And thank you to the participants and the Narrative Study staff for their time and support. Thank you.
I've really been looking forward to hearing this presentation, so I'm glad we finally did. Thank you so much, Angelique. I had just a comment. I think it was quite interesting, and I'm hoping Barry's and Alzette are still on here. We're busy doing a very similar project about the utility of whole exome sequencing results in the DDD Africa project. And I found it very interesting that they valued a negative result so much, because you as the genetic counselor, I guess you know better, but it almost feels a little bit disappointing when you don't get something. But for them, they see a lot of utility in that, which was really nice to
Absolutely,
see.
Monica. I think that's also one thing that's changed the way I think about, as a genetic counselor, the way I think about delivering negative results, because I always viewed it as something that's very disappointing and that they might be upset about. And just through this research, it's changed my view completely, where, you know, participants do, or like actually just patients in general, may actually just really value this because it's an answer in itself.
Yeah,
Definitely.
Definitely. Does anyone else have any questions for Angelique? Or any comments? Tina's got her hand raised.
Hey, nice to speak. I was going to ask you, the communication came through strongly, hey? Communication or the individuals in the study, and this thing around being, you know, having genetic counselors involved in research, and where do we get involved, and do we only get involved when we feedback results, and what about consent, etc. I mean, given what you were saying about the importance of follow through and follow up and keeping connected with them, what do you think the role of a genetic counselor could be in, for example, this DDD project, where Barry is busy? Barry also has some thoughts.
Thank you, Tina, for the question. I think definitely we've got a very important role there. When you think about a researcher's obligation to disclose research results, they don't really have a duty to disclose any results. But I also think there's so many barriers, funding, skills, skilled people to be able to feedback these results. I think there are so many gaps that can be filled by a genetic counselor. So, you know, we can maintain that contact. Like I said as well, you know, the time since contact with a researcher, that time lapse has a major influence on whether they feel that they're going to receive a result or not. So genetic counselors can be that gap as well, where they can, you know, follow up with the patient or keep the patient informed, see the patient regularly. That's just one of the things we could do. We definitely can help in where there's lack of understanding, which I didn't address in this presentation due to time, but where there's a lack of understanding certain concepts or confusion over certain concepts. Genetic counselor is trained to do that and equipped to do that. So we can definitely be involved in all of that as well. So I think we just kind of, we can be the glue between, you know, the patient or the participant and the researcher, because where they do not have the funding or the time or the other means to actually get to the patients, like, you know, that's a role we can definitely play.
Agree. Isn't it interesting? Willem started off talking about genetic counselors being the glue. The glue, or what did Willem say, Monica?
Yes,
did he say connective tissue? The connective
tissue, that's it.
Angelique,
and I found that, yeah, I found that so interesting, because I felt like with every research project that was conducted here today, there was some link. We were all linked somewhere along the line, you know, with similar findings here and there. And it's, yeah, it's amazing.
And in so many areas.
Yes, absolutely.
Thank you so much. For everyone who's been following in the chat, there's been a lot of interesting conversation, and I think it's probably worth us having this conversation at another point, you know, about how we get involved in increasing the uptake of cascade or family testing with variants, BRCA and breast cancer variants in general. So it's been so lovely, and it's been so nice to see so many people engaging with our presentations today. Okay, so I'm going to hand over to Nikita. She's going to do some closing remarks, and then that's it.
Thank you, Monica. I don't think I need any more introductions. Just hold on. Sorry, I had to just look at Tina and get her to turn off her computer. So my first thanks is really to you, Monica, because I think without you driving this this day or this afternoon wouldn't have been as big a success as it has been. And obviously to Kelly and Next Biosciences, you know, we really are so grateful for your sponsorship for the CPD points. And I think that is also what has drawn in a lot of people to come here this afternoon. But I think that coming here, maybe just for CPD points, they've come up with a lot more because of the fantastic quality of the research that our students and interns and qualified genetic counselors now have presented of their time and their training. I really, really enjoyed today's webinar, and I'm so excited to try and continue doing this in the years to come. I think that, you know, a big thank you to the speakers for sharing their research. As I said, it was really great quality, and I really think that you're assisting with advancing the field of genetic counselling, and not only in a South African setting. And I think I really do encourage you all to publish your research as far as possible so that we can get this out there, and we can get talking to one another, and even those that didn't present today to please doing that as well. Also do think that, you know, what I really took out of today is that there's such an opportunity for collaboration here between us as a community. And I was quite excited by all the overlap that we're seeing, and how much we can maybe work together. And I think that was also part of the point of today's research showcase, you know, to get us all talking together, to get us in one room. And I'm really grateful. So let's all be that connective tissue, but also let's be it with each other. And thank you for that term, Willem. I'm going to be using that from now on. And yeah, I hope to see you guys at the next showcase. And thanks everyone for attending this afternoon.
Thank you.
I hope everyone has a safe drive home, if they're not home.
Thanks, Nikita. I'm going to leave the link open for a little bit, just so whoever wants to fill in the attendance register still can. I'll leave it open for a few minutes and then I'll close it. Thank you so much to everybody who attended.